Welcome to the Anesthesiology Journal Podcast, an audio interview of study authors and editorialists.
Hello, I am BobbieJean Sweitzer, an associate editor for Anesthesiology, and you are listening to an anesthesiology podcast designed for physicians and scientists interested in the research that appears in our journal. Today we are speaking with the author of a publication that appears in the November 2021 issue of the journal. With us is Dr. Gavin M. Hamilton. Dr. Hamilton is the lead author of an article titled Persistent Postoperative Opioid Prescription Fulfillment and Peripheral Nerve Blocks for Ambulatory Shoulder Surgery, a retrospective cohort study. Dr. Hamilton was an assistant professor in the Department of Anesthesiology and Pain Medicine at the University of Ottawa and Ottawa Hospital Research Institute in Ottawa, Canada, while conducting this study. He is currently working as a full-time anesthesiologist at the Queensway Carleton Hospital, a large community hospital in Ottawa, Canada. Welcome, Dr. Hamilton.
Thank you for having me on the show.
So let's start out. Maybe you can just tell us what the primary question you intended to address with this study.
For sure. So the primary question with this study that we conducted was to estimate whether peripheral nerve blocks were associated with a reduction in persistent post-op opioid use in ambulatory shoulder surgery. And for this, we used prescription fulfillment pharmacy data. The time frame that we were interested was the first year after the surgery. And the reason that we wanted to examine this issue is that we know that peripheral nerve blocks for shoulder surgery reduce early postoperative pain. But what was less clear to us, and I think is less clear in the literature, is whether peripheral nerve blocks are associated with reduction in persistent postoperative opioid use.
So I think you used three different terms to kind of classify the patients into different categories of their opioid use, I believe, pre-surgery. And so I was hoping you could maybe define for us what you meant in the article by opioid naive, opioid exposed, and opioid tolerant.
Like you said, to quantify preoperative opioid use, we used a modified definition of the patient's opioid exposure status prior to their surgery that was outlined in a recent consensus statement in ANA. So specifically, the definitions for an opioid-naive patient was a patient with no history of opioid use in the 90 days leading up to their surgery. An opioid-exposed patient was a patient who had a history of less than 60 milligrams of morphine equivalent dose of opioid per day in the 90 days prior to their surgery. And then an opioid-tolerant patient was a patient with a history of greater than 60 milligrams morphine equivalent dose per day in the 90 days prior to surgery. And the reason why this classification is so important for our study is that the definition of persistent post-op opioid prescription fulfillment, which was our primary outcome, is based on the patient's preoperative opioid use.
Okay, and we're going to dive into that a little bit more. But first, we're going to clarify a few more things. I presume since you only looked at patients who received a 2-month supply of opioids that were at least 90 days after surgery and up to 1 year, as you stated. So the primary intent of your study was not actually whether the regional anesthetic technique provided acute postoperative pain relief, but rather whether it impacted only chronic opioid use. Is this correct?
So that's exactly correct. So we were primarily interested in the association of regional anesthesia and persistent opioid use in this population, so not the opioid use within days to weeks of the surgery.
And what type of study would you classify this as?
So this was a retrospective population cohort study, and it was conducted using routinely collected healthcare data. We conducted the study in Ontario, Canada, where a universal health system exists.
And how many patients overall did you have enrolled?
So in our study, there were 48,523 patients, and all of these patients underwent their elective shoulder surgery at one of 118 Ontario hospitals.
A lot of patients. And how were you able to determine if the patients filled the prescription postoperatively?
So to determine if patients filled a prescription postoperatively, we use the Ontario Narcotic Monitoring System, or short form NMS, which is a provincial system that was introduced in 2012 to capture prescription opioid drug claims for all of Ontario residents. And the way that this system works is that each individual pharmacy, they submit all their dispensing data for monitored drugs to the NMS. And this initiative was started back in 2012 to try to help facilitate a better understanding of the use of these high-risk medications in Ontario.
And were you actually able to determine if the patients took the opioids that they were prescribed?
Thank you very much for this question, and it's an extremely important point that you bring up. So since this was a retrospective cohort study, we were not able to determine whether patients actually took their prescribed opioid. We basically used the assumption that if a patient filled their prescription, then they took these opioids. So that is definitely a limitation of our study, and this is why we actually ended up changing the terminology around our primary outcome to be opioid prescription fulfillment rather than postoperative opioid use, which a lot of studies do use. Like I said, it's a limitation of the retrospective nature of the study, but we do know that the pharmacy data that we were using for the study is very accurate.
That's why you use that word fulfillment.
Yes, exactly. There's a little bit of back and forth between us and the reviewers about that one.
Sometimes we spend an inordinate amount of time over one word, right? So were the nerve blocks just single-shot regional anesthetics or catheter-based techniques or a mixture of these in this population?
So our paper included a mixture of both single-shot and catheter peripheral nerve blocks. So we identified whether a peripheral nerve block was performed on the day of surgery using the Ontario Health Insurance Plan, which is basically just physician billing codes. And with any retrospective study, it's really important that you use a validated outcome and exposure to ensure that we're confident with our conclusions. So as such, all of these billing codes for the peripheral nerve blocks were previously validated by our group against a clinical reference to demonstrate their accuracy. And they are both sensitive and specific at about a 97 and 94%, for correctly identifying that the patient either had the presence or absence of a peripheral nerve block. And although that we did include both catheter and single-shot blocks in our study, we did find that there were just 4.5% of the nerve blocks were catheters, and the rest of the patients received a single-shot peripheral nerve block.
Got it. So I know in the past, many patients and providers actually believe that opioid exposure for acute pain or injuries or surgeries did not predispose patients to chronically use opioids. But I believe that logic has been proven to be faulty. What do we know about surgery and the risk of persistent opioid use?
So many times, surgery is the first time that patients become exposed to opioids. And there's quite a bit of evidence to suggest that after either acute care hospital visits or a surgery, many of these patients will go on to persist in opioid use. Now, as you know, this is very complex, and quantifying this risk is extremely challenging. The way that I find it a little bit helpful to think of the risk of persistent post-op opioid use or post-discharge opioid use, it's within a framework. So imagine you have a Venn diagram with three different sets. One set is the system factors, which include your prescribers, your healthcare system, and potentially patient follow-up. You also have then the surgical factors in a different set, which would include your type of surgery, the type of anesthetic that the patient receives. And then the third set would be your patient factors. And these factors are probably the most important factors. And what you'd include in there would be your risk factors for going on to persistent post-op opioid use, which would be chronic pain, preoperative opioid use, history of substance use, depression, things like that. So unfortunately, the evidence in this area is quite heterogeneous with varying populations and definitions for post-op opioid use, but in general, it's likely that the incidence of persistent post-op opioid use ranges from 6% in the low-risk, naive patient coming for a surgery to up to 60%, depending on those factors that I mentioned.
Those are also potentially, though, huge numbers considering the amounts of surgeries that we do, correct?
Oh, for sure. for sure.
So can you tell us a bit more about the database that you used?
So we're fortunate in Ontario that I already mentioned that we do have a universal physician and hospital health insurance coverage. And because of this, all of the healthcare data in Ontario are collected using standardized methods, and they're stored at a research institute centrally. And so in our study, we utilized de-identified data from several of the different data sets. So, for example, one of the data sets names was called same-day surgery. Another one was called the Ontario Health Insurance Plan database, the NMS database, which I've already spoken about. And all of these databases needed to be linked to conduct our study.
And did you have a lot of detailed information about these patients, such as their comorbidities, and I assume you knew their age?
Yes, we did have quite detailed information on our patients. So for retrospective studies, as we are not randomizing patients upon inclusion into the study, like you would with an RCT, it's extremely important to be able to control for as many potential confounders that you can in your statistical methods. And because of this, we decided to obtain detailed information on demographics, comorbidities, preoperative opioid prescription data, preoperative patterns of healthcare resource use, because these variables are likely to confound the association between the peripheral nerve block and then persistent post-op opioid use. And just to give you an idea of the population that was included in this study, so the mean age of our patients was just over 50 years old. 34% of the patients were female. About 65 of these patients had an ASA score of less than 3. And regarding the preoperative opioid use, about 75% of the patients were opioid naive, 22% of the patients were opioid exposed, and 3% were opioid tolerant.
So a very small percentage of patients were using a large amount of opioids immediately before surgery, correct?
Yes, exactly. That's correct.
So quite impactful, I guess, if you did find some persistent use. So maybe tell us what you found.
So of the just over 48,500 patients that were included, 63% of the patients received a peripheral nerve block for their surgery. And then we found that 17% of patients, which was just over 8,200, went on to have persistent post-op opioid prescription fulfillment after their surgery. With regards to our primary analysis, we did find that there was a statistically significant association between the receipt of a peripheral nerve block and a reduced odds of persistent post-op opioid prescription fulfillment. The adjusted odds ratio was 0.9 with a 95% confidence interval of 0.83 to 0.97. Now, although this was statistically significant, the significance of the association that we found in our primary analysis is unknown, as when we went on to do our sensitivity and secondary analyses, we actually did not find a consistent relationship throughout our analyses between nerve blocks and a lower rate of post-op opioid prescription fulfillment. And then when we did stratify by preoperative opioid use status, 8% of opioid naive patients, 44% of opioid exposed patients, and 61% of opioid tolerant patients went on to have persistent post-op opioid prescription fulfillment. And we also found that preoperative opioid exposure did not modify the association of nerve blocks and post-op opioid use.
So if patients were using more opioids pre-op, they were more likely to be using persistent opioids, but there was no difference between the block and unblocked groups.
Exactly.
Got it. So were there any differences in chronic opioid use in the patients having the single shot versus the catheter? I know you said you didn't have a lot of catheter patients, but still your numbers were pretty big, so even that 4+%, right?
Yeah, exactly. So in our full population, we did find that the use of a catheter technique wasn't associated with decrease in persistent opioid prescription fulfillment. But interestingly, in quite a small number of opioid-tolerant individuals, and that number was just over 1,000, so 1,111, So the use of a catheter in 29 patients was associated with a reduced odds of persistent post-op opioid prescription fulfillment. And that adjusted odds ratio was in the range of 0.46 with a confidence interval of 0.26 to 0.79. But again, we do need to be quite cautious given the small sample size and exploratory nature of this finding. So for sure, future study is required to examine the potential long-term benefit of catheter nerve block techniques, but it is encouraging that potentially a catheter could be beneficial in this population.
A little bit of good news there. So I was intrigued by one of your statistical methods, which personally I am unfamiliar with. You used, quote, coarsened exact matching, unquote, to create the two groups, the peripheral nerve block and versus the no peripheral nerve block groups. Can you explain to me and our listeners why you use this in your study and what this is?
So for our primary analysis, we used a multivariable regression model that accounted for clustering of individuals within hospitals using generalized estimated equations. But then we went on to test the robustness of our primary analysis. And to do this, we used, like you said, the CEM or coarsened exact matching, which, as you can probably infer by the name, is an analysis based on matching to control for confounders rather than a regression model. So basically, it's a type of monotonic imbalance bounding used to pre-process your data to create two groups that are identical within the coarsened ranges of each variable. You might wonder then how this matching technique compares to propensity score matching, which I'm sure the listeners might be more familiar with. So the main difference between CEM and propensity score matching is that propensity score matching matches individuals on average across covariates, whereas CEM requires an exact match that you predefine in your model. So therefore, the CEM analysis technique is thought to be less model dependent and may have lower bias as it requires fewer assumptions. So our CEM model matched on all covariates that were included in our primary regression analysis, including an exact match on hospital. So for those listeners who are kind of interested in the specifics of what we did in this analysis, I would encourage you to take a look in our digital supplement.
Thank you for that tip. So have other studies looked at the issue of chronic opioid use after surgeries and specifically after regional techniques? And if so, what have they found?
So we're aware of one other retrospective study that has also examined this issue. So it's a paper by Mueller et al. In 2017 from Eric Sun's group at Stanford, and they examined peripheral nerve blocks and persistent opioid use in ambulatory shoulder surgery. So they also found no association between persistent opioid use and the receipt of a peripheral nerve block in patients undergoing shoulder arthroplasty. Not specific to shoulder surgery, several other studies have examined these issues in other populations. And in 2012, a Cochrane review was conducted to examine whether regional anesthesia prevents chronic pain after surgery. And that review included 23 RCTs and did find that regional anesthesia may be associated with a reduction in chronic pain, but only in specific populations. And they found that those two populations were thoracotomy, and second one was paravertebral blocks for breast cancer surgery. The Cochrane review did not find any convincing evidence in orthopedic populations for regional anesthesia to affect persistent opioid use. And it is worth noting that within this Cochrane review, there was a small shoulder RCT of a total of 40 patients, and they also found no difference in the VAS pain scores at 1 year after acromioplasty surgery.
So what were the dates of the surgeries in the cohort that you were looking at?
So we included patients who were undergoing ambulatory shoulder surgery between the dates of July 2012 and December 2017. And the reason why that we chose the start date as such was because this corresponded to the introduction of the narcotic monitoring system that we previously spoke about. And the end date was the latest complete data at the time of our cohort creation.
So do you know if the patients that you included in this study received prescriptions for opioids immediately in the postoperative period, or is it possible that they had recurrence of pain or some other painful condition that prompted the later prescriptions?
So we did look at this, and one of our secondary objectives was to examine opioid prescriptions in the immediate 14 days after surgery. So we looked at, first of all, whether a patient filled an opioid prescription in the 14 days after their surgery, dichotomous variable. And secondly, we also looked at the total quantity of opioids that were filled immediately postoperatively. And we did find that the majority of patients, 94% of patients actually, filled a postoperative opioid prescription within 14 days of their surgery. And there wasn't a statistically significant difference in patients that got a peripheral nerve block or not. We also did not find any difference in the adjusted oral morphine equivalence that was prescribed between patients who did or did not receive a peripheral nerve block.
So do you think it's possible that the surgeons in 2012 routinely prescribed postoperative opioids regardless of the need, and perhaps today they would be less likely to do so?
I think that could be possible. And interestingly, our model did show that the year of surgery may have modified persistent post-op opioid prescription fulfillment. And we did see that there were fewer post-op opioid prescriptions filled in the more recent years of the study. So for sure, this is an encouraging finding. And like you suggest, it could be reflective of the continued public health messaging around the risks of misuse and morbidity from opioids. And in general, and clinically, I also do think that post-surgical opioid prescribing is something that has shifted to become a little bit more deliberate and evidence-based over the last decade. Although there's still a lot of work to be done in this area, I think we may have made some headway on this.
I believe the American Society for Enhanced Recovery and Perioperative Quality Initiative consensus statement recommends regional anesthesia techniques to be used to reduce opioid consumption after surgery. Considering the findings that you just shared with us, what do you think of that?
So I would agree with this recommendation, and I would agree with it in the sense that there is strong evidence to support the use of regional anesthesia to reduce acute pain. For sure, that could then lead to reduction in opioid consumption. And in addition, it's possible in patients with chronic pain that peripheral nerve blocks can also reduce peripheral nerve hyperexcitability and consequently reduce further central sensitization. So I think what's less clear is whether a peripheral nerve block can then affect longer-term pain outcomes. And our study, granted it was a retrospective study, although quite large, it did not find that peripheral nerve blocks contribute to reducing persistent post-op opioid prescription fulfillment. I also think that it is important to add that although regional techniques can be extremely beneficial, I don't always think there's a one-size-fits-all for pain management. And I think it's extremely important to be utilizing individualized multimodal analgesia pain management strategies for all of our patients.
So do you see a role for anesthesiologists to be perhaps more involved in decisions about how best to manage postoperative pain beyond like the PACU or the immediate kind of, few hours or day after surgery?
For sure. So given our specialty's expertise in pain management in the perioperative period and our experience in dealing with complex chronic pain patients, I do think that we are extremely well positioned to make contributions in this area. And it's so encouraging for me to see the development of several transitional pain programs in our Canadian healthcare institutions which have evolved for this exact need.
I hope today's discussion will interest many of our listeners and lead you to read this important article to learn more. Thank you, Dr. Hamilton, for discussing your work with us today. I wish you well as you continue your efforts to enhance the practice of anesthesiology and strive to improve the care of our patients.
You've been listening to the Anesthesiology Journal Podcast, the official peer-reviewed journal of the American Society of Anesthesiologists. Check anesthesiology.org for an archive of this podcast and other related content.